Good evening, everybody. May I request the members to please take their seats. We will be starting our program very shortly. Dr. Rudra Prasad Ghosh, Dr. Shugato Paul, Dr. Onujit Paul. A very good evening, ladies and gentlemen. Ophthalmological Society of West Bengal deems it's a privilege and an honor to welcome the Phaco emulsification wizard from Brazil, Dr. Rosatelli, in our midst. We are honored to have him here, and we will enjoy this evening, a Saturday evening with him, going through his life stories, going through his videos, going through his surgeries, perhaps learning from him down the line. With that, may I request my colleague, Dr. Pradeep Mohanta, to have an introduction of Dr. Rosatelli.
Welcome, dear respected seniors and my dear colleagues. I have a long association with Dr. Neto, maybe for the last 10 years or so. He didn't know me, but he uploaded a video of mine in cataractcourse.com about my submarine chop technique. And there he mentioned that I have learned this technique from Dr. Pradeep Mohanta. And I was surprised that somebody in Brazil, a surgeon who is probably the highest volume cataract surgeon in this world, is recognizing me and giving credit to me. It was so much amazing to me. Dr. Neto is a very humble and nice person. He does about 30 to 36,000 surgeries in a year. And I asked him, when did you decide to come to ophthalmic field? And he said, when I was in fourth year of like MBBS course in our there it is fourth year of medical school. At that time, he got interested in ophthalmology, and he would go to ophthalmic department in his free time. So ophthalmology is his love from when he was just a medical student. And now, second question I asked him, how did you learn surgery? And he says, he started surgery in the first year of his residency program itself, and he didn't go to any place to learn Phaco. He learned on his own and developed these techniques on his own. And now I asked him another question, did you have any practice? Yes, he started practice in 1990. In 1998, he thought of doing high volume surgery on massive scale under the support of Brazilian government, Brazilian public health system. And since 1998, he was doing surgeries. And in 2017, he left his practice after 28 years of practice to dedicate totally into this service of humanity, to get vision to the people. Today is a Diwali day, and on Diwali we light, we get lamps. Neto is giving lamps to blind people's eyes. And now, we will, rest of the thing, we will learn from him itself. And now, about Agda. She is the driving force of Neto, and she looks after everything, the massive scale surgeries, overseeing how people are managing the whole show. That is done by Agda. Credit to you. Thank you very much. And along with this high volume surgery, Neto takes utmost care to maintain quality. We are going to see that. With these few words, I would ask Shubhen to add to something what I have said. Shubhen, please.
Good evening, everybody. It's a pleasure and honor to welcome my dear friend Neto, Ma'am Agda, to this city. In fact, our city, we are privileged to have you amongst us. Very few cities in the country would have had the pleasure and privilege of having him come and see him live and speak to him and on a one-to-one interaction. So we are deeply honored. Thank you very much for gracing our city and us. Neto, well, I call him by his first name now. Well, when Jose de Melo Rosatelli Neto, that's his full name. That's a, and what strikes you when you interact with him is his humility. Skill apart. Skill is something which it will take us years to achieve, his skill. His humility, his friendly attitude to anybody and everybody. See his interactions on social media. He's so eager to teach. He knows so much. He never claims to know so much. And that is the beauty of a learned man. Thank you so much for enriching ophthalmology by your posts in social media and your interactions. So I now hand over to Dr. Debashish Dash, our secretary, to go through the felicitations. Thank you.
It will be our honor to felicitate you, sir. Dr. Rosatelli, may I request you to be on our dais? Apurva. May I request our members, Dr. Shubhen Bhattacharjee, Dr. Sudipta Mitra, Dr. Deepa Shaha. May I request Dr. Deepa Shaha to please hand over a bouquet to sir. May I request Dr. Sudipta Mitra to give the... This is customary, sir, in India. And may I request Dr. Shubhen Bhattacharjee to hand over a plaque to him, sir. We are so happy to have you with us, sir.
Thank you, my friends. I have really, I'm speechless to thank you properly for all this kindness and this hospitality and love that I have been receiving here. I'm so glad to be here to share experience and to make friends here. So really, it's a wonderful day for me or night. And I'm very, very happy. I thank all my friends, especially Suvan and Pradeep, for arranging for me to be here. And I hope I don't tire you too much for the things that I'm about to show. And I really would like this to be like an open reunion, an open occasion that you are free to ask questions and we discuss things. So I think that's the best way to develop this evening. So thank you very much for all that. I'm really touched by all your love. Thank you very much. Well, what I would like to present here, it's really many things that I think it would be of interest for you. And I tried to quiz these so that the presentations wouldn't take too long. But let's see how it goes, because some of them I couldn't, let's say, resume too much or make it shorter. But I wanted to show many of the details that I know that there are many things that you're curious about, how we develop these things. And I think it's most important to pass this to everyone that is interested about how I do my work, how I do my surgeries, and let's say how I see the way I see and aim to do my work in cataract surgery. I will start with this one, which is on how to enhance your surgical performance. I think this is the most important one because when we talk about high volume surgery, people think differently. And I'm going to show that the way to achieve high volume surgery with quality is not in the way that most people, let's say, think or imagine it is. What is the meaning of high performance cataract surgery anyway? It's not that. It's not speeding. High performance surgery means excellence in surgical technique and, yes, efficiency in both surgical time and material use. All this to achieve the best surgical outcome for the patient. What are my thoughts on cataract surgery? I think it's something extremely personal, meaning that each surgeon has an almost unique way of operating, from handling the instruments to approaching a particular case. That is why it might be reproducible between different surgeons, or definitely not in some cases. It can be said that there are as many Phaco surgery techniques as there are surgeons, meaning that each surgeon has a personal one, which can be an adaptation from existing techniques or a completely new one. It becomes clear then that there is no best Phaco technique. That's something very personal for each surgeon. By refining techniques and achieving proficiency in surgery, the surgeon can achieve what can be defined as art, in the sense that is the expression or application of human creative skill and imagination. Still, not only in a visual form as art is commonly defined, but also in a functional way. Over time, the patient expectation of cataract surgery has grown increasingly, and surgeons must keep up with that. So first of all, how can you improve your surgical techniques? What I am about to say is essential to achieve that. First, deliberate practice. This means performing each surgical step deliberately with care and attention to proper technique and standards every time. Work in a consistent environment, having everything you need at your disposal. Perform immediate result evaluation to check that if you are providing a good result for the patient. This is a well-worn concept, but it is an absolute truth. Phaco surgery is a step-dependent procedure. The poor execution of a surgical step can compromise the rest of the surgery. Of course, it is difficult for a novice surgeon to practice this, but it mostly depends on attention, determination, and knowledge. The surgeon must keep in mind all the theoretical technical aspects and requirements for the successful execution of that surgical step and stick to them at all times. Good surgery requires control of the processes and maneuvers involved. Effectiveness, efficiency, and safety depend on that. Therefore, only proceed if you have control of the intra or extra-operative situation. Avoid performing the surgical step with no control, just by doing it and getting rid of it soon and moving on to the next step. This is a big mistake. An imperfect incision has incision leakage and will cause a surge during nucleus emulsification. A small rhexis can cause a radial tear when handling a harder nucleus. The effort in perfect execution is what promotes improvement. Practicing a movement the wrong way will teach you to do it wrong every time. Practice makes an act permanent in its execution, so always perform it perfectly and correctly. Don't worry about the subsequent steps of the surgery. They will come later and depend on the step you are doing now. So concentrate on it and take your time. Time pressure is usually the main factor that makes a surgical step poorly performed. Contrary to popular belief, the perfect surgical step always saves time. The surgeon must have an efficient team to help. Leading by example is the way to go. Task given should be equal to task done. My OR team rotates everyone's position frequently. In this way, everyone knows how to work in every OR position. Team pride, confidence, and companionship ensure happiness and effectiveness. I always say, my surgical team is my family. Without them, I am nothing. Optimizing surgery performance is the easiest and fastest way for the surgeon to improve it. What does that mean? It means eliminating or reducing as much time as possible between the surgical steps, or idle time, which is time wasted. As we will see, this brings both gains in time and other important advantages. Perfectly trained assistants or trained scrub nurses are essential. The assistant must know exactly what is happening in the surgery, what instrument or device the surgeon will need at every moment, and how to hand it over to the surgeon and receive it. This allows the surgeon to focus exclusively on the surgery, not on the surgical table, wasting time looking for and preparing instruments. The organized surgical table allows the notion of where each instrument is, streamlining the process and providing safety. Everything needs to be ready before operating. Surgical material, consumables, the lens to be used, etc. It's important to anticipate possible difficulties in the case, review the history and the examination data, and prepare material and supplies in case of a change in the surgical plan. Establish action protocols for the different surgeon scenarios you might encounter as much as possible, diminishing decision-making situations. Concentration, focus, and attention of the surgeon in the surgeon, reduced surgical time is beneficial in every way. Lengthy surgery causes greater trauma, inflammation, risk of infection, etc. Finally, faster surgery has lower costs for the operating room and the surgeon. If you can operate on 10 patients in one morning instead of spending 2 mornings on it, you gain free time to do other activities, and your time is quite expensive. The greater productivity in the OR is very welcome, especially when you operate in an OR that is not yours. You will be seen and treated as a special partner and not as someone who takes up a room to do 2 surgeries all morning and gets in the way of the whole schedule. I was showing this video while I was talking to show how proper integration between the surgeon and the assistant, be it the one who is handling the instruments, the other one which is on the Phaco machine. This gives the surgeon the opportunity, this makes the surgeon able to focus only on the surgeon and no wasted time between surgical steps. This is the best way to improve your surgical time. I always recommend surgeons to record their own surgeries and review it. And time all the, let's say, the time between surgical steps, and they are almost always amazed to see that the time doing some surgical step is much less than the time wasted between when you take instruments out and put instruments inside the eye. This you could see it like 5 seconds at most between surgical steps. This makes a surgery much quicker. Recording, reviewing, and studying your surgery significantly accelerate the surgeon progress. Get used to making that routine. Don't worry about creating a sophisticated, high-quality recording system now. A simple and inexpensive system is sufficient for this purpose. And today you have many options, including smartphone recording, etc. Recording provides the opportunity to identify errors in technique, situations where the surgeon systematically has difficulties, and learn from your own complications. In reviewing his surgeon, the surgeons will see things he cannot see while operating because attention is focused on the surgeon. Show your surgeries to experienced surgeons. Ask them to comment on their mistakes and successes and consider the suggestions for improvement. Today, we have access to a plethora of techniques, tips, and information shared by numerous exceptional surgeons on the internet, which we all can learn from. Observing a technique being performed correctly helps in improving and understanding. We are very efficient at learning through observation and imitation. As we learn and progress, we can see details in the techniques that we didn't notice before, so always come back to the videos to study them. Do active observation, watching a more experienced surgeon do what you couldn't. Take the opportunity to learn from the complications of other surgeons. If I only had one tip to give novice surgeons, it would be to always ensure the best pupil dilation possible. Meiosis is an unnecessary complicating factor. The surgeon already has a whole series of difficulties with the technique, device, microscope, patient. Obviously, no need to have another. Insufficient dilation is almost always the result of poor preparation. In my daily practice, attention with adequate dilation is absolute, saving me from many problems. As take-home message, I could say that always keep improving your surgical techniques, regardless of your skill level or experience. Build and cherish your team. This is the key that allows you to go to another level of surgical skill. You can't afford to be cheap. Quality surgical instruments and equipment always pay off in the long run. The way to surgical excellence, speed, and efficiency is perfection in execution, not hurry. Of course, the right mindset is essential. Never be satisfied with your abilities. Have the humility to see your limits and be able to improve. I would like to go to the other presentation where I would show some details of my work, which I think it's the, let's say, probably the things that you are most interested to hear.
Can we have a little question and answer over here at this stage for your techniques and OR techniques?
Yes, of course.
So the floor is open. Anybody would like to ask questions on how he makes the things so efficient? Like you saw, he barely takes his eyes off the microscope. So anybody would like to ask a question on that, on whatever has transpired so far?
So how did you train your staff so well so that there is no wastage of time between surgical steps? How did you train so well?
Okay, most of them are with me have been with me for more than 10 years. And when they start working inside the OR, they usually start positioning the patient, which is something that let's say, requires less technical skill, and it's a position that the assistant is able to observe how let's say, things flow in the room. And as they are more, let's say, familiar with how things are going. Usually Agda teach them, and they, let's say, if I have one person that stays on the Phaco machine and changes the Phaco tip and gives me the Phaco handpiece, they usually start there as, let's say, being scrubbing stereo and to help me. So they sit, they are beside the assistant that is performing this task, and this technician teach the other during the day. As we, let's say, we have a very high volume for many, many days. Sometimes we stay like 30 or 45 days doing surgeries in many cities. In a, let's say, in a short period of time, the new technician, let's say, is able to learn very much. And and then they are rotating the stations. Let's say we work like, I could compare like a volleyball team that rotates every point. So every city that I go, I'll show this, they change positions, they rotate. So the one who is in the Phaco machine goes to the main surgical table. The one that was on the main surgical table goes to do instrumentation, and they are rotating also, positioning the patient, and at the sterilization room, cleaning material, working on the autoclave. So everyone knows how to perform every activity. This has many advantages. The first one, if I have some problem with someone, let's say it's sick, it couldn't go, they can change, they can shift positions, no problem, because everyone knows how to do everything. The second one is no one has a more privileged position, because some places you work, let's say, more, and in some places you work less. So as they are rotating, everyone does the same thing all over time. And this brings a much better understanding of when they are, let's say, the ones that are positioning the patient, they, at a certain point, they open the IOL and they give some let's say, some things to the one that's instrumenting me. As he also knows how to instrument, he's performing this, he knows the right time up to what time he should open the IOL, everything that he needs. So the team knows all let's say, the tasks perfectly and very integrated. This is important because the operating room in a setup like that, high volume surgery, must, let's say, it's like clockwork. It must be synchronized so that the flow goes without the need to hurry. People that visit me is amazed because we do like 100, 120 surgeries a day. And they say, Neto, it's no hurry, it's so calm, so tranquil, because everything works like that. This is the key to...
So let me understand. Now you operate at a stretch on 30 to 35 days at different locations.
I'm sorry.
So you have a mobile unit.
Yeah.
What's your team like? How many people?
Oh, yes. It's not, let's say, we, many years ago, I had the opportunity to work, let's say, what we should do. We could say mobile units. I will show, yes, like an operating theater on a semi-truck. Nowadays, no. We have 3 clinics in 3 different states of Brazil, and I operate also in many hospitals. Nowadays, I only operate in hospitals, but I take everything, like the microscope, the Ingenuity system, the Phaco machine. We have 2, let's say, a backup that goes with me, because if one machine fails, we are far away, so I don't have time to wait for the technician. We have 2, everything in duplicity. Let's say, all the equipment to make the preoperative evaluation and the disposables, and 4,000 or 5,000 IOLs travel with me because we do biometry on the same day of the surgery, so we must have all the range and everything else. When we operate in hospital that we are not ours, they give us the operating theater completely empty. We take everything. Usually my team is able to set up the operating room in about 1.5 hours. Everything is ready, and then let's say, I am very proud to say that we comply with every sanitary, we have how do you say, an organ, yes, Anvisa, which is
You have an audit system. Audit system.
Yes, and we comply with everything. All our surgical instruments go like on the rapid autoclave cycle with drying time, everything else with rasterability, yes, with the indicators, so that.
So how many vehicles? How many vehicles? How many?
How many?
How many vehicles? How many cars or buses
Oh
do you
yes,
carry?
we have one big truck and 2 or 3 vans that that travel with us, and I have about 70 kits that we use, 70 surgical kits. It's really, when my colleagues say, Neto, let's say I want to do surgeries like you, what do I need? They usually think that the most important thing is the surgery. I say, you should come to watch my crew load up our trucks, and then you will get the idea of the Herculean job you must do to perform that, and you think twice, because it's really, let's say, a very complex operation. You must have everything. I'll show in this presentation.
I have a quick comment and the question.
Yeah.
So we have grown up from childhood supporting Brazil in the World Cup. Pele, Zico, Ronaldo, Ronaldinho, and I'll probably not be wrong calling you Pele of cataract surgery.
Oh.
So my question is, if you're doing 120 cases, different countries have different protocol. Do you scrub between, after each case, you get scrub again, hand wash and scrubbing? Or what's the protocol in Brazil?
No, we change gloves, we change the Phaco tip, the Phaco sleeve, we change the Phaco handpiece at about 10 surgeries. And let's say in most cities I operate, our routine is to do bilateral surgery, sequential, but we change everything between the eyes. And at about 20 patients or 1 hour and a half, we take a break. I go outside. So I think we divide this group of surgeries in about 1.5 hours for the crew for me to get up. And the Ingenuity system really helped me in terms of ergonomics, because I can operate on a more comfortable position and etc.
Thank you so much.
So this one I will be showing much of what we discussed now, and I think it will explain many of the difficulties that we have and we have to overcome to perform high-volume surgery. How can high-volume, high-quality surgery be achieved? It's a question of teamwork. You have to prepare your team. You must have a good team. This is most essential. That's the main thing. When people say, Neto, how can you perform so many surgeries with such quality? It's teamwork. So you have to train your personnel, prepare everything, and they must know how to perfectly perform their tasks. Also, you must get local personnel to help from the hospital, from the government, from the health agency. So you depend on them. In our system, in our health system, I depend on them, for example, to do the scheduling, the patients, and as we operate on the frequently on one city, but we attend like a 2-kilometer radius area. They are poor patients, they are needing patients, so the government, the local agencies provide transportation and everything else for the patient. So this is a key factor too. The place must be prepared to receive 200 to up to 500 people per day. Because you're not going, let's say, if I'm going to perform surgery on 100 surgeries per day, you have to have some kind of overbooking because many patients won't be able to be operated that day because of blood pressure issues, some other clinical conditions, and everything else. So, besides the patient, most of them come with some member of the family to help, to get instructions, etc. You have people from the city that the health secretary, I don't know how to say. Let's say the agency, the health agency of the city that is providing that. So it's a lot of people. And it's not easy to receive 500 people in a hospital. So you have to prepare for, let's say, bathroom, food, water, everything, because usually they spend a great amount of time there up until the surgery is completed and the patient is getting is receiving instructions and waiting for everyone on the bus. We receive a lot of bus. So this must be taken in account. When a city says, I need to perform surgeries from my city, we say, please, we are going to be like this city on next month. Visit us so that you see how it works. You will see what you will need to provide in your city to be able to do this. Of course, careful patient scheduling. This is very important. We sometimes we have some mishap in that, and let's say we're planning to receive like 150 patients to get evaluated, to get screened, to get surgery. Someone schedule them on another day, and then we receive 100. And then on the next day, we receive 200 patients because of a scheduling error. And it's very difficult to, let's say, send them back because they have traveled 200 kilometers. And so we have to be able to perform surgeries on, let's say, a bigger number than we were prepared. So this is not an uncommon situation. Of course, having all the material, consumables, IOLs, etc., we usually carry on our trucks twice the number of the material we are, let's say, planning to perform surgeries. So in a month, if we're going to perform 1,800 surgeries or 2,000 surgeries, we carry twice of that. So to be prepared for any unplanned thing. You must have backup equipment. If something breaks, you must be able to perform your task without having to wait for a technician, etc. And of course, what I did was to break orthodox surgical paradigms. That's how I modified my surgery to be able to perform the surgery with quality and with less time. That's how I developed all my surgical techniques that most of you know. You must have a large reception area. Usually, as I said, pupil dilation is most important. So when you immediately when the patient is identified as someone who is receiving surgery, pupil dilation begins. Ophthalmologic examination is done, surgery indication, biometry and IOL selection is usually done on the same day. We have clinics where we are able to examine the patient and schedule them prior the surgery, on the, let's say, before the day of the surgery. But in most places I go, this is done all in the same day because transportation is not easy. Patients come from afar. Patients have difficult, let's say, very old patients which has some have difficulty of walking, have orthopedic issues. So you must be efficient in diminishing the number of times that he will need to come. And we're usually able to receive the patient in that day and do everything, operate him, and he goes home, and then he returns on the next day to be examined, and then depending on the case, up until for 7 to 30 days after that.
How many doctors screen those patients? How many doctors or optometrists screen the patients, whether the patient is a surgical case or not?
Usually one is sometimes two, but one does all of that. In the morning, he or she screens the patient, and in the afternoon, the patients are returning for the first day post-op. So in the morning is screening, and in the afternoon usually is post-op one evaluation. And then we schedule the next evaluation depending on the case. But usually between 15 to 30 days after surgery, the second visit.
You are not screening the patient. Some other doctor is...
No, yes, someone does. I usually follow some cases that, let's say, some cases that are some complicated cases, if we have it, and some cases that I'm interested in, some technique I'm developing, I see them also, but it's not a common thing. I usually only perform surgery. So when the patient enters the room, it's the first time that I see him or her. Yeah.
One question from me. Hello, this side. You said that the patients are usually coming from far away, 200 kilometers. After the surgery, if the patient develops some sort of complications before 7 or 15 days, where do they go?
Yes, in these cities that we are operating them, they are what we call, let's say, they are central health agencies. The city is like the responsible for healthcare for all this area that we are operating on. But on the cities, we have our bases, our facility, and doctors that accompany patients, let's say, all over the time. So if the patient has some issue in his or her city, they send them to
That means
this.
if necessary, they travel that far distance. If necessary, the patient will travel that far distance.
Yeah.
That means from his location where he did the surgery and where he will take care of his complication. That means say maybe 200 kilometers.
Yes. I don't know if I understood, but they, in some cities, some small cities, there are
Can we explain what I asked?
Yeah, I will help you. Yeah,
Yes.
Neto here. So the question is, now let's say you do a surgery. The next day, you don't see the patient.
Yeah.
Your team sees the patient.
Yeah.
Right. Now, when does the patient go back home?
Oh. The patient goes
Back to his
returns
city.
on the same day he did surgery and then comes back on the next day. I don't know if it's...
Yes, okay. So now if the patient has a complication,
Yeah,
let's say, God forbid, patient has an endophthalmitis
yeah.
at day 3. Now, who sees this patient?
Oh, he comes, okay, the patients are oriented to look for the health
Local health.
locally. All their cities, all the cities have local care, and they send us. Also, we have they receive like an, I don't know how to say, an 800 number.
Okay, a helpline.
Yes, a helpline. Yeah.
Yes.
So, and our nurse orient what is, let's say, what is it for him or her to do. If she, let's say, go see the local doctor in his city, which all of them have, because they have sent us. They have a pre-screening on the cities before they say. So,
Okay, so-
they have a local.
Doctor to take care of the patient.
Yes,
Okay,
but
good.
usually they, of course, they don't perform surgery. No, they identify the problem and send to us.
Let's
Yes.
get on with your presentation and
Yes, that's how it works. So, biometry and IOL selection is performed at the same day, and then patient preparation, let's say blood pressure check, oral sedation, disposable surgical gown, etc. And then they go to a large surgery waiting area where dilation continues, and the patient enters the OR in, let's say, in a strategic order. They must be very well dilated. The dilation time is recorded, and if for some reason, after, let's say, the expected time, he or she is not well dilated, it's because it has some issue, usually diabetes or pseudo-exfoliation, something like that. And then he is brought to me. And the one that performs this is Agda. She is outside monitoring everything, how the patients are. So sometimes if we have, let's say, too many patients in the waiting area, and we are worried about the dilation time will pass, let's say, she chooses the best dilated one so that we can, in a faster way, go. So there are many details to make the surgical flow go well, and let's say to keep up with the patients that are coming. And some complicated cases, she chooses what time they will enter, like a subluxated lens, a very hard cataract, or an IOL exchange, something like that. It's not like, say, it's usually at a certain time, strategic time. Sometimes we are, let's say, in a very fast, we are operating very fast, and we have some issue at the autoclave. We have some cycle fail. We know that it's possible that we will not have enough material sterilized on time, so she puts a case that will get longer so that we optimize this time. We establish our methods, protocols, and strategy. This is most important inside the room. I showed something about on this video, but there are many things that I will show in 1 or 2 videos afterwards. Patient companion, both are oriented. Prescription is given, medication. We give the medication to the patient. We provide the eye drops and everything else because patients the medication is not very expensive in my country, but if we don't give this to the patient, they won't have it. So we give everything, and patient is discharged. I was asked on a webinar with Surab and Deepak Megur about my Amazon expeditions. And they asked me, what has this talk taught to me? What has this experience brought to me? Well, in going very, very, let's say, limited access places or faraway places, I saw that there is absolute need to leave no open ends, no complications left behind. Your responsibility is absolute, as you mentioned, like a patient with endophthalmitis or something like that. And with all that, I am very proud to say that our last endophthalmitis case was in the end of 2017. It has passed 90,000 surgeries without one single case of, and this is due to many, many factors like all this care, but it's amazing to achieve that in high volume surgery and with, let's say, poor patients, with poor compliance, with many difficulties that they face, like they don't get to use the eye drops correctly. And so it's amazing that we are achieving that. And we, let's say, we absolutely know everyone that has a complication, because this is referred by the health agent. There's no way that a patient has some complications and we get not to know. So this is very, let's say, we show that it's possible to do that.
Right. Can we, Neto, can we move to the surgical techniques? Can we move to the surgical techniques?
Oh, yes, okay.
Because I think that will be of greater interest to the audience, the surgical techniques.
Okay. I would like to show, yes, I was going to show some videos of the operating room before.
Go ahead.
Okay.
Go ahead. Please go ahead.
Yes, please show.
Okay.
Yes, please.
So, I left the sound on just to see how tranquil the ambient is. So I'm going describing what is happening. I'm starting to operate on patient, and the technician is preparing the table. You saw on the other video that the table is absolutely organized on the order the instruments will be used, and this is makes things very efficient. This is a panoramic view from the Phaco machine side. The patient is being taken out and another patient is brought in. I'm changing my gloves. The tables are switched. I'll have some videos that show this in more detail. We usually take like about 40 to 60 seconds to change patients. Yeah. The surgery is usually about around 3 minutes. So in a, let's say, in a regular rhythm, a normal pace for us, we do like 15 surgeries per hour. It's possible to do many more, but this is the pace that I like most and that we maintain with this is very regular. It's amazing. I can calculate at about what time I will finish the day by calculating this, and it's almost always like that, 15 patients per hour. I always wash the patient with the irrigating line of the Phaco, and I think this helps very much to prevent endophthalmitis, because you clean the eye this is a technique I described, and so surgery is starting, and I think in this video, let me see if, oh, sorry, let's continue. Oh, I changed it, but no problem. Let's go to another one. The patient is being taken out. I think this video may show, I brought these videos, these are I think the things that most of you are more curious about, how the operating room flows. So next patient is laid down. I'm with the glasses because I'm operating with the Ingenuity. You can see the camera there. My technician took the used instruments there, and the used instruments will be taken immediately to the sterilization room. Many things during surgery I communicate with gestures. You will see when I point is go. I say let, is stop. When I say like that, that let's start. This is a most efficient way to communicate with them without talking, because when we are operating, that's a problem. I have this problem. If I'm going to ask for the chopper, for example, it doesn't come to my mind the word chopper, but I do like that, which is the shape of my chopper, and they know. So if I say like that or like that, they know it's the sapphire keratom or the side port blade. So it's the best way to communicate. I can, but usually I don't have to. You see, I don't take my eyes off the screen, and the technician gives me. I don't even look. I know where the instrument is coming. This barely passes my mind that I'm doing like that. I'm just looking at the surgery, and this is what makes possible for me to concentrate, to be absolutely concentrated, focused on the surgery. He's loading the IOL in the cartridge. The technician knows that he or she has during nucleus management, they load the IOL. They are very proficient in it. They can load any kind of IOL. And he's on standby with the next instrument on his hand, which is the irrigating probe. I give the handpiece, and then I attach the irrigating line. I'll insert the IOL. I'm trying to see and then we'll see a whole, let's say, a whole changeover. So it's 340. That's what took a whole case, including putting the patient. So it goes like that. So in a 1 hour, 15 patients, it goes very smoothly, and the whole cycle. The patient has her cap marked just for reference for me, because let's say I know that it will be both eyes that will be operated. You can't hear it, I think, on this recording is too low, but as when the patient is laid down, one of the guys that is putting the patient on the surgical bed says for me like IOL 21 diopters and astigmatism -1 at 0.90, so that I can plan my and any other particularity of the case.
So if you have a toric IOL, when you're doing toric IOLs, no torics?
We don't because here is the eye prep. Okay, the patient gets the eye prep on this chair, and when he or she lays down, I just finish putting the surgical drape. We pre-cut the surgical drape We don't cut with after putting. This saves both time and this. I think if you, let's say, I really don't like the scissors to pass over the cornea for that. So it's I think it's a better way. So we in the public health system, we are not able to provide premium IOLs. Even if the patient can afford it, we can't use it. If the patient says, no, let's say I can buy, someone, my ophthalmologist friend my friend ophthalmologist will give me, we say, we can't use it. This is something that is defined by regulations to avoid, let's say, someone could charge the patient, say, no, you can put an IOL and then charge the IOL extra for that. So this is to avoid this kind of thing with every kind of prosthesis in the public health system. You must use the standard one or else the patient will be operated. And sometimes we have indication for, of course, premium IOL, especially younger patients that will lose accommodation. We say it would be better for you to operate somewhere else. And as like in before, when I had my private practice and doing surgeries under contract for the public health system, I couldn't operate this patient in my office. He said, no, doctor, I want to be operated with you. I said, no, I can't operate you because I attend on the public health system. I can't, let's say, bring you to my private office. This is forbidden. You must go to some other colleague. So this is to avoid some issues like that. I wanted to show this because this is one of the things that surgeons ask me the most. How do I hold the chopper? I don't know if you can see. I usually use the two little smaller fingers as a support. These are whole surgeries, so that to show how long it usually takes. This will take about 4 minutes total. But you see that there is very little time switching instruments. This is what makes the surgery shorter. Of course, as I do hydroimplantation, like I'm doing this, I don't have to evacuate the OVD afterwards, so this saves time also. Many of these techniques I began developing when I was in the Amazon because of the high volume that I was needing to be operating. I'll just very quickly show some photographs of the setups that of my work, so that you have some idea. Okay, this is my wife. She's always in the first time in everything I do. And this is Agda and her mother, which is also a technician nurse. And my friends say, Neto, you were really amazing because you got to get your mother-in-law to work for you. You were amazing. So they always laugh when I show this. And as Pradeep asked me, here is Agda teaching the technicians, teaching all the techniques that we use. This is in here. This is a mobile unit. This is inside a truck. I'll show more details. This is the biometry room. You can see this. This is the whole. Of course, you have many on the inventory, but the patient is examined, the IOL is selected, and the patient holds his or her IOL up until the surgery. This is the best way to avoid switching. So no naming confusion. Of course, the IOL gets a name and it's checked, but this is the fastest way. This is the main surgical table organized. This is the day I met Agda, 14 years ago. Yeah. So this is our clinic in São José dos Campos, which is, I usually perform about 600 surgeries per month there, and it's very near São Paulo. And I'm showing this because I'm inviting all of you. You are very welcome to visit me and see and accompany my work. I think this is the best place because it's a very big facility. The operating room is big. It's where I receive most of my the friends that visit me. This is our other facility in other city, which is here Chapecó. It's another state. This is what I was talking about, the need for transportation. In some actions, we get help from the Brazilian government, the Brazilian Air Force to transport things like in the Amazon region. So sometimes by boat. And this is my van. This is in front of my house. This is my van. This is where I pass a lot of time. And some trips from city to city are about 1,200, 1,300 kilometers. It takes like 16 to 18 hours. This is where I edit most of my videos, inside this van, because that's when I have the most time. Yeah, yeah. I'm able to edit some 3 or 4 videos during this. So in some places we are only we have only access by boat in the northern region of Brazil. These are the trucks that these are mobile units. And when we operate like in these situations, patients arrive at about 3 or 4 a.m. so that by about 7 a.m. we are able to start everything because of the volume. These are many doctors' actions. It's not what I do right now, but I did participate in many of them. So you can see an operating. I'm lost with the mouse here. Yeah. Okay. Here is in this room. It was we were in 5 surgeons performing surgeries like that. So this is a setup that we use it to do with two surgical beds in a V configuration. When we are operating this one, this side is being prepared. So the switching. Let's say, to go from one patient to another usually would take like 10 seconds. With this setup, I'm usually able to perform 200 surgeries per day. With one surgical table, which is what I do now, and it is what I prefer. I don't like doing like that. It's too much. It's very difficult to maintain, let's say, quality. It's too much. But 100 patients we can do comfortably with one surgical table. That's what I try to stick to now, to do like that. And, well, in these actions, this is, let's say, doing patient orientation and etc. It's a whole different setup. And this is to show sometimes when you do actions like that with many doctors, this is, we take a peek outside the room and say, my God, it's we have to do all that. This is to show some of our perspectives. And our team, let's say, like I said, My team is my family. You have to keep them happy, to cherish them. This is a mobile unit. This is inside a truck, a semi-truck. It opens like that. It has, I don't know how to, like a drawer, you know? And so you wouldn't say this is inside a truck. And so in this kind of setup, we have 3 surgeons with 6 surgical tables. And then we call surgical island, each one, which has a Phaco machine, a microscope, technicians, and everything else. This is the mobile unit for office. You have 6 examination offices to, let's say, do screening for the mobile. Usually there is one truck which is the operating room and another with the office. We use it like that. And a lot of what I do is not only surgery, let's say, working on the public patients. I love to go to meetings, and it's very difficult for me to get out to let's say, for some time to participate in some meeting is very difficult because you have to rearrange my whole schedule. And this was in Lima when I won a video prize of hard rock cataract. And was right now in Cordoba, Argentina. And this is me mentoring surgery at the university in São Paulo, Unifesp, teaching Phaco, and on this slide here on the right, teaching SICS, because in Brazil, I can safely say that less than 30 surgeons know how to perform SICS. The ones who perform manual cataract surgery do it like limbo incision. And in most residency programs, manual cataract surgery is not taught anymore. So I'm striving to keep this going and making actions to teach manual cataract surgery to people. This is my hospital in Ribeirão Preto with some partners. When I had my private practice, I operated there, and nowadays I only operate there when I'm at home and my friends find out that I'm there and go, Neto, I have some surgeries for you, and then they bring some difficult cases. But so my practice is very, let's say, it's varied. And this is another thing that I think most of you don't know. Let's say, I still have this intention of setting up a surgical, ophthalmic surgical instrument factory. Yes? No, that's not yet. No, I have everything. I have many. This is in my home besides my bedroom, upstairs. I have a shop, a machining shop there, but I have some CNC machine, lathes and mills, etc. On another place, and I love to develop surgical instruments. This is developed by me, but I don't have time, unfortunately. So, but I love here. I love this, and this is to show some aspects of my work. And as I said, outside work activities with your team brings friendship, trust, and proximity. We really are like a family. We work so much together. Let's say, we know each other like brothers. We feel like brothers. This is most important. And my team does, let's say, I don't know how to say, they really protect me, they cherish me, and they give their blood for me, and they're very proud of their work. This is very touching to see, and you can only achieve that as treating them as family. That's the secret of it.
Great.
Maximum number of surgeries in a day you have done.
I'm sorry.
Maximum numbers in a day. How many surgeries you have done?
Oh, yes. It was 2 times I say I had because it was not my intention. I had to perform 232 in one day. This was in occasions like what happened was what I said, that let's say the patients were scheduled for one day and they came on another. When I was operating with 2 tables, which was what I did up until the beginning of COVID, 1918, 1919. My mean surgical, my average surgical number was 175. Nowadays it's 105 to 110 because I changed it, I switched it to 1 table only, and I restricted the number of surgery because I'm getting old. I'm 60 years old. I must tell you, doing all this high number of surgery per day, it's a very difficult task. So I think this is what I think it's, let's say, the maximum ideally. We have a very huge backlog of cataract surgery in Brazil, so we must do, and the high volume, the high number of surgery is important for economy of scale to make this viable. Because, you know, in Brazil, we have a universal access public health system, and cataract surgery has a special financing program. All the surgery, the government pays for it, but it's not, let's say, we as a company, we receive around between $200 to $300 per surgery. This must account for everything. So we must do it in a high number to be able to have all this.
So the question is, how was the funding arranged? Funding, where does the money come from?
The Brazilian government in 1998 began to contract third parties to perform some healthcare in strategic areas. Cataract surgery was the first of them, and breast cancer prevention and some diabetes care, and there are some other areas. So it's a special funding from the Brazilian Ministry of Health that is separate for cataract, and they have, let's say, studies that assess the need for each area, and they make a bidding process, as we call a licitation. Is this an English word? I don't know. Like a bidding process.
Bidding, okay, yeah.
Yes,
Auction-like.
Yeah, auctioning for third parties to apply to perform this kind of surgery. And let's say, there are not many in Brazil that are able to provide what is needed, because you must, there are very high numbers, you must have quality and everything else. So it's a special funding program, and the amount, you have a minimum that is set by law, that is about $200, but it's usually about $300 what is paid for each surgery, and this is much cheaper for the Brazilian government than to perform surgery in their own hospitals with people, let's say, under contract of them.
So you are in a contract with the government,
Yeah,
that they will pay you, say, $200 to $300 per surgery.
yeah.
And this goes through a bidding process before that.
Oh,
So
yeah.
there are other netos also? Are there any other?
Oh, yes, yes. But you know, Brazil has 20,000 ophthalmologists. Yeah, I think India has 27,000.
Yes.
Yeah.
Yes.
But we have 220 million people, and India has over 1,400 million. I think actually 1,400,000,000.
We've lost count.
Yeah, okay, yes. So, I can imagine the difficulty you have here, but without that, there are not many surgeons able to do this. Well, let's say, we in Brazil that are high volume surgeons, at one time just before COVID, I was doing between 3 to 5% of the surgeries of cataract surgery in Brazil, I myself alone. And I have some other friends that do it. And they are constantly asking me, Neto, do you know someone who I could bring to my team to perform surgery, because most of them want to perform high volume to learn, and this is not a place to learn. I can safely say that 80% of high volume surgeries in Brazil are over 50 years old. Okay. Because you can't afford to train people in this volume. You will get too many complications. That's not the way, the place to learn surgery, doing high volume surgery.
Total number of surgeries you have done till now. Do you have any record?
I do, but Pradeep, this is something that I usually, let's say, refrain from saying, because it conveys the wrong. No, I can say, but it's not something that I advertise. In Brazil, I do not talk anymore about high volume, because you see that slide that I showed with Locke, as in the beginning with the Ferrari boot, people think like that. I'm almost reaching 300,000 or 3 lakhs, yeah?
Yes.
300,000 surgeries, 209,000 and 95,000, about that. But I've been performing cataract surgery for a long time, so this is not. But,
okay, Dr. Devdash Mukherjee wants to know how much time you take for cleaning the cortical cleanup.
Oh, in about 80% of my surgeries, there is no cortex left, because I perform the spin, which is a
I think that's what we would like to see.
Yes,
if you can show us some surgical clips, that will show us how you maximize your time efficiency.
Yes. There were some techniques that I developed to enhance that, to be more, let's say, efficient in time, and at the same time providing safety for the surgeon. I'll talk about this on the spin. Okay, what is the nucleus spin? It is a fast and repetitive nucleus rotation. That's why I named it the spin, in both clockwise and counterclockwise directions. The spin is performed after hydrodissection, but it is not that small and simple nucleus rotation intended only to free the nucleus. The purpose of the spin is cortex release, achieved because the nucleus rotations drag the epinucleus and cortex along, detaching them from the capsular bag. But why cortex release? Why is it important? Cortex management, of course, is an essential surgical step. It is time-consuming, including the need to switch instruments. Cortex removal can present difficulties. Subincisional, equatorial, and posterior capsule adherent cortex can be challenging to address. Intraoperative meiosis can hamper cortex visualization and making its removal troublesome. Most importantly, it has been shown that most posterior capsular rents happen during cortex management. It is clear then that it would be beneficial to facilitate or eliminate this surgical step. And two maneuvers can help it. One is the well-known and universally used cortical cleaving hydrodissection, but it often is not enough to achieve that. In conjunction with the super or over rotation, the spin, complete cortex release is achieved in most cases. In my experience, 80% of the cases I have no cortex after nucleus management. The spin technique is simple. It should be performed right after hydrodissection, with or without hydrodelineation, this is up to the surgeon, under irrigation by the Phaco probe or under OVD, using an instrument like the chopper itself or a Sinsky hook, any instrument, auxiliary instrument, almost any can be used for that. And the spin can be performed in both phaco and also small incision cataract surgery. Let's watch the technique. Right after hydrodissection, I free the nucleus with small back and forth movements using the long chopper. The multiple clockwise and counterclockwise rotations are performed 10 times in each direction, as here, as this helps in removing lens equatorial epithelial cells. Any phaco technique can be employed for nucleus management afterward. Here, I use the carousel technique, which is one I like very much. No cortex or epinucleus remains. About 2 years ago, I started to evolve the spin to achieve even better cortex release, incorporating a technique I developed, if you have time I'll show, for posterior polar cataracts, the mechanical cortical cleaving, which is the mechanical detachment of the cortex from the capsular bag, performed by sweeping a long blunt chopper along the lens equator. In this way, the sweep and spin technique was created. I first performed a mechanical cortical cleaving on 180 degrees of the lens with the chopper, and then continue in the same movement by doing the regular nucleus spin rotations. So what are the advantages of the sweep and spin over the regular nucleus spin? The sweep maneuver promptly and effectively detaches all cortex from the capsule from the bag in at least 180 degrees. The already separated cortex is dragged along, helping to detach the remaining cortex. As cortex detachment is more effective, fewer nucleus rotations are needed. It is even faster than the regular spin. In the regular spin, when I don't perform the sweep maneuver, I usually perform 8 to 10 clockwise and then counterclockwise rotations. When I perform the sweep and spin, usually 2 rotations for each side are sufficient to achieve the same amount of cortex release. And now I'm showing the sweep and spin. This is important. Gentle hydrodissection. The less fluid, the best. Then, before nucleus rotations, the long blunt chopper traverses the lens equator opposite its entry side, separating the cortex from the capsule and dragging it along. Nucleus rotations begin, and now all cortex is detached and carried with the nucleus. Only a few nucleus rotations are necessary, as I commented, with this technique variation. Nucleus management is then routinely performed, and no cortex is left upon completion. Let's watch another case. Please pay attention to how the cortex is detached and dragged along. This greenish image is a custom digital filter I developed for better contrast and definition of the capsule and cortex in the Ingenuity system. So a few nucleus rotations are performed after the sweep, and then after that, very few cortex is left. I have other videos, but I would like to show some different technique eventually. Well, in conclusion, both techniques were developed to enhance cortical release, conferring safety and abbreviated surgical time. The spin is straightforward to learn and execute, the simple spin, I mean. I recommend surgeons to master this technique before moving to the sweep and spin, which is more effective but more challenging to master. The sweep and spin requires a long chopper of 2 to 2.5 millimeter in length for maximum effectiveness. The simple spin does not. One can slowly build the skills required to perform the spin and the sweep and spin and increase surgical efficiency and safety. In this presentation, I have more examples, but I think this is illustrative. So it's so maybe before we move on to another technique, it would be if you have some questions, I think it's better now.
I think everybody is speechless.
I'm sorry?
Everybody is speechless. I said everybody is speechless.
No. I apologize. I have a very bad hearing. Yes, and sometimes I don't know. So I apologize for.
You've been gifted in many other ways.
Thank you. So I think the spin is not a difficult maneuver. The sweep and spin is, and people, let's say, the thing that I am, people ask the most about this technique is, are the zonules affected? Is this, let's say, how it is for the zonules? It is very zonular friendly because the forces applied are in a tangential way and distributed over the entire zonular apparatus. The sweep is amazingly, let's say, when you're performing at the right place, it's amazingly smooth. And you see no traction at all because the capsule separates. And the way it works is not very intuitive. You would think that what is separating the cortex from the capsule would be the chopper itself. It is not. The chopper acts like separating, making them a little distant from each other, and ahead of the chopper goes let's say a detaching line, like if you would peel how do you say, a sticker, like as you would peel a sticker. So when you pass the chopper, there is no resistance at all. What is, let's say, there is some risk is if the patient moves his or her head or the eye in an aggressive way, you surely will have zonular detachment. So this is the biggest problem you would have. I usually do not perform if I notice there is some zonular compromise. I don't do the spin. I prefer to employ other technique because we usually don't know how much the zonules are fragile up until we begin to work the nucleus. So I prefer to employ other technique. But this is something that I would like to comment on.
So I have a question. You have wonderfully demonstrated this case in case of softer cataracts, but do you think that this work equally well with harder cataracts like NS grade 3 or grade 4, the spin technique?
Oh, usually in softer cataracts, the spin is, I wouldn't say more effective, but the harder the nucleus is, of course, there is less cortex, and in hypermature cataracts, there are some adherent cortex that the spin really doesn't take out. So I think this is, I employ the spin technique in all of them. In harder cataracts, I usually don't spend, let's say, 10 rotations. I just move the nucleus because I know it will make no big difference in cortex release, because the cortex that will remain is cortex that is very adherent and the spin is not able to release that. But in softer cataract is amazing. And there is something that it's very, it's surprising is, I don't know if it's surprising, but in softer cataracts, it is better to perform the spin without hydrodissection, the sweep and spin, I mean, because you get cortex release in almost 100% of the cases. But performing the sweep and spin without hydro in harder nuclei, you get too much zonular traction.
So in case of leathery cataracts or cataracts who are having a plate in the posterior pole, what's your preferred technique of chopping? In cataracts, harder cataracts,
yeah,
like leathery cataracts, those are having a posterior plate.
Oh, yes.
So
yes.
what's your preferred technique of doing the
Oh,
nucleus?
undoubtedly, the one that I perform the most is the submarine chop. This completely changed my practice. And I thank my dear Pradeep for having devised this, because it's a very reproducible, effective, and efficient technique. I perform it differently because I do horizontal chop and Pradeep do mostly vertical chop, but the concept is the same. Is using your auxiliary instrument to keep the nucleus still, and the Phaco probe must travel inside the nucleus. And in very, very hard cataracts, sometimes I do some kind of pre-fracturing. I have I use a technique with the Jakobovits pre-chopper, which is a little similar to Dr. Sohel's pre-chopper. I think it's only smaller. And then I do some pre-chopping with it. But most of my harder cataracts, I use the submarine chop. And there are many, many surgeons in Brazil that employ that. I have said sometimes a lot of time to Pradeep that he has no idea of how many Brazilian surgeons follow his channel and learn his techniques. He's let's say, he's a pop star in my country. When I said to them, I'm going to be with Pradeep, it would say, oh, that's amazing. And so they were so happy. And so I must thank him again for this and many others. I learned much about SICS watching Pradeep's videos. Yeah. Okay, I would like to show just one more technique, because this is, I think, the one that breaks some paradigms, and it's, let's say, it's a little hard to believe it works, but it has a lot to do with the spin. Okay, I'm going to talk about the mechanical cortical cleaving for posterior polar cataracts. This is a technique I developed to approach posterior polar cataracts, and this technique is amazingly effective, and I have been using it for some years with great success. It was curious about the way I developed this, and it was because I started doing this technique that I modified the spin to do the sweep and spin, because I could see how this is effective. Okay, just remembering a posterior polar cataract is a round, discoid, opaque mass that is composed of malformed and distorted lens fibers located in the central posterior part of the lens. This is its most significant feature, but we must remember that at the proximity to and possible adherence with the posterior capsule makes this a little challenging to approach. And this is a dominantly inherited disorder with variable expressivity. I don't know the incidence here, but in Brazil, we could say that it's about 3 to 5 in 1,000. I have the opportunity, if I would like to say, it's not something that I have expressly assessed, but I could say that I perform about 10 to 15 posterior polar cataracts per month. So it's a lot. Posterior polar cataracts are challenging cases due to the often present thinness and fragility of the central posterior capsule that, along with other abnormalities, demands a different approach than those used in routine cases. Most posterior polar cataracts are operated at a much younger age, patient age, than usual, and the soft nucleus management might be a difficulty factor. In the traditional posterior polar cataracts approach, cortical cleaving hydrodissection is usually contraindicated because the fluid wave pressure may cause hydraulic posterior polar capsular rupture on a weak point. Careful hydrodelineation helps by isolating the central nucleus core and facilitating its removal. But this approach usually has a problem. With no hydrodissection, all cortex and usually a thick epinucleus shell are left, which is laborious to remove, demanding much manipulation. So, what are the usual traditional recommendations for posterior polar cataracts? No hydro, or if done only at the edges, hydrodelineation is beneficial, but nucleus rotations are usually contraindication. Some recommend low irrigation pressure and to work in a relative hypotony. It is crucial to avoid anterior chamber collapse. This is most important. That can stretch the posterior capsule and a rupture may ensue. Achieving a perfect rhexis is essential. So, in posterior polar cataracts with no hydrodissection, a thick adherent cortex epinucleus shell usually remains, posing difficulties and hazard in its management. I then developed the technique to release this shell from the capsule in these cases, which is the mechanical cortical cleaving for posterior polar cataracts. This is a typical appearance of a posterior polar cataract. Please note the central discoid opacity, surrounding vacuoles, and degenerated lens material. Remember, when dealing with posterior polar cataracts, performing a perfectly centered and sized capsular rhexis is imperative, as it can provide support for a sulcus placed IOL with optic capture as a plan B, should posterior capsular rent happen. So, what is the mechanical cortical cleaving? I mechanically detach the cortex from the capsular bag using a long blunt chopper. The chopper traverses the space between the cortex and the capsule 360 degrees around the lens equator. By going from two opposing side parts, access is granted. Usually from the right side, I go under OVD, and from the left side, I go with the Phaco probe irrigating. So I similarly complete the maneuver from the left side. This time I am under irrigation from the Phaco probe, and I think this enhances the action of the cleaving. The nucleus then can be safely rotated to make sure all attachments are released. Routine nucleus management can be performed according to the surgeon's preference, greatly facilitated by the previous step. In the vast majority of cases, no cortex is left. I have another video here that here that will show how safe is this technique, because sometimes you can't assess how fragile the capsule was, and this video is a good one to show. In here, we will also see how an adequately performed capsulorhexis is an essential asset in complicated cases. Avoiding hydro makes it challenging to deal with the remaining thick and firmly attached cortex epinucleus shell. I'm going again from the two opposing side parts, traversing the space between the cortex and the capsule. I usually prefer a chopper with a bent portion of 2.5 millimeters, which is it's more effective in this. And then going from the left side under irrigation, we can see that the lens mass is entirely free. I rotate a little. I'm using the wedge technique, which is a mechanical chopping technique to divide the nucleus, and easy management follows. And you can see that no epinucleus or cortex remains. Only the diseased central portion. I don't let it to the anterior chamber to collapse. And now we see, upon the slightest touch with the IA probe, the capsule opens. Of course, this was a mistake. I shouldn't have tried to remove that. But you saw that after, even with all the manipulation with the mechanical cleaving, the capsule was okay. I rotated the nucleus, but I just touched it with the IA, it opened. So what I did, no vitreous come out. I implanted a 3-piece IOL in the sulcus, which would be the best choice in this, and I performed a posterior optic capture to ensure the IOL centration. This is why I stressed the importance of making a perfect rhexis. And then the case ends up well. So this video I brought to show how the maneuvers that seem maybe overly aggressive are very, let's say, gentle, or even with a very diseased posterior capsule, it didn't open.
Did you have any nucleus drop in the last 5 years?
Oh, yeah, sure. I think, well, when we get more experienced, we rarely have, like, say, a whole nucleus dropped, because we usually are able to perceive the, let's say, the more risky cases and employ some technique that don't. But some pieces sometimes happen. Usually when we, let's say, and I can say this is up to, because of my fault, we, as Phaco surgeons, I'm eminently a Phaco surgeon, and my SICS skills are not really on par of that of Pradeep or Sunil or Deepak or any other Indian surgeon. I'm really, let's say, I consider myself a beginner surgeon in terms of SICS. And many cases that I should have approached by SICS, especially with zonule dialysis in some parts. So when we attempt Phaco in some cases like that, then you have a significant zonule dialysis and you haven't implanted a CTR, it's not uncommon from some nucleus fragment to
when
go
nucleus
up
drop happens when you are doing surgeries one by one, and nucleus drop happens, what do you do to that patient? You keep it for another day?
Yes. One of the reasons that I use the Constellation machine is because with me, my fellows that perform the preoperative evaluation are all retina surgeons. Because over the years, I saw that the most important evaluation I must, let's say, the most critical evaluation I need to have for these patients upon the screening is the condition of their retina. Because sometimes you are going to operate patient, you must know in advance if they had a macular hole and how is their diabetic retinopathy and everything else. So they end. As I have the constellation, if I have something like that, I clean, and then usually on the final day of my, let's say, I don't implant IOL, I finish the case, I do an anterior vitrectomy, whatever is needed, take out the cortex, close the eye, and then my VR surgeon addresses this on our last day. So yeah. Let's say, we are prepared to address that. In some cases, like in São José dos Campos, where my colleagues are there, they usually, when I finish surgeons, we set up the machine for posterior segment, and on the same day the patient is operated. So it's no problem of waiting. But thankfully, this is rare. But it happens, of course. It happens to all of us.
Let's move on to the next technique, and then we'll have to wind up.
Okay.
Yeah.
Well, I think this is the last technique that I would like to show. It's the wedge mechanical fracturing technique, and I'll show some details. This is a Phaco technique I developed to achieve maximum efficiency in soft and medium hardness nuclei, and I use it in the vast majority of my cases. The wedge chopping is a mechanical fracturing technique, meaning that no vacuum or ultrasound is employed to divide the nucleus. The nucleus division is achieved by compressing the nucleus piece between the chopper and the Phaco tip. Mechanical fracturing is a well-known Phaco technique, and many surgeons use it. So why the name wedge? That refers to a modification I made to the technique by positioning the tip sideways. Its bevel acts like a wedge to initiate and propagate the cracking, cleaving the nucleus fragments while the chopper holds it. So, it is then a horizontal chopping technique. A long bend chopper with a blunt tip is recommended, usually with a 2 millimeter or bigger bent portion, and a ballpoint for capsule safety. The chopper acts embracing the nucleus equator. And now the important detail. The Phaco tip goes sideways to present the bevel as a wedge. 45-degree tips are better suited for this technique. Using irrigation only, the chopper compresses the nucleus material against the Phaco tip, and the tip's wedge initiates the fracture, which is propagated along the natural cleavage lines of the nucleus. After complete nucleus division, the pieces are routinely emulsified. I'll first show the critical detail of the technique, how the fracture is performed. The aspiration and vacuum settings remain at 0. No ultrasound or fluidics are used to achieve the fracture. The tip goes sideways and the chopper hugs the nucleus, being brought horizontally towards the end of the bevel as the fracture begins and completes in a clean line. This is a crucial difference between wedge and traditional mechanical fracture techniques. The sideways bevel has the shape of a wedge, and it is at the bisector of the bevel angle that the compression vectors propagates, initiating the fracture, as you see, and the compressive forces are concentrated in a small area, making the action more effective. Here then is the complete technique. Notice the sideways position of the tip, which appears as a wedge. The long chopper is ideal. The one I use the most is 2.5 millimeters. Rotating the nucleus, I go completely dividing it into 8 pieces, although the 4-quadrant division is the most common method. The fracture propagation in the fragments can be seen following the natural cleavage lines of the nucleus. By using the Phaco tip's bevel sideways acting as a wedge, the nucleus is divided using only mechanical forces. No ultrasound or fluidics are employed. Only then do I proceed to pieces emulsification, sequentially, one by one according to its location. Merits of this highly modular approach becomes clear as control, safety, and ultrasound usage efficiency are outstanding. What are the advantages of the technique? The wedge chopping is very easy to learn and master, with no need to change the surgeon's machine's setting. It can be performed with basic or lesser machines and also associated with other techniques and during pieces emulsification. Nucleus hardness for 1 up to 3 can be approached by the technique, which is the majority of cases for most surgeons. The ultrasound power applied in the case is significantly less with the technique, which is important in the general sense, but especially in cases with compromised corneal endothelium. And by using no vacuum or ultrasound, safety is one of the hallmarks of the technique. If efficacy is maximized because the compression forces are applied in a very small area by the tip, with easy cracking. The Phaco tip stays in the safe zone at all times. The chopper does most of the manipulation. And as it does not depend on vacuum, it's very fast. I strongly recommend you all to learn and use the wedge chopping mechanical fracturing technique to enhance overall efficiency and safety. It is a valuable technique that can be used in most of your surgeries alone or associated with other techniques. It's not a difficult one. I think most surgeons can master it very quickly and can be used in most of our nuclei. And here I would show the same thing. Okay. Well, I have many videos of these techniques on YouTube and many others, and I ask you, please take a look. So I try to show many different techniques on my channel. Of course, not all, only the ones I use. There are many, many techniques, and many surgeons all around the world send me videos of their techniques, and I try to master and to show. And I think it's like I said, watching other surgeons' techniques is a valuable way to, a very effective way to learn new things. Thank you very much.
I think the Brazilian wizard deserves a standing ovation.
So thank you all. Today it's a great honor for Dr. Neto Rosatelli, sir. So we are very much enriched with your procedures, and I am very fond of used to watch the videos and seeing in front of you. It's a great pleasure for us, all of us. And we are very grateful you just land here at 4 p.m. and join the session. Thank you all of you for attending this program and make it successful. Thank you the moderator, sir, Dr. Shubhen Bhattacharya and Pradeep Mohanto, sir, for being with us. Thank you, Sunways, for offering this program. Thank you all.
please do join us for the dinner. Thank you so much.